Imagine a dear friend, a family member, yourself, living life with a terminal illness, aware that its end stages can include significant loss of function and severe pain that may not be subdued by medication. What options might they and you want available? The Right to Die, ahead on Wide Angle. Today's conversation is not for the faint of heart. In fact, it challenges us to engage with issues we often invest significant energy in avoiding: death, and more particularly, the right to choose the time and circumstances of death for some facing terminal illness. Joining me today to discuss medical aid in dying, as well as legislation currently being debated in statehouses across the country and on Beacon Hill, is Marie Manis. Marie is the Massachusetts campaign manager for Compassion and Choices, the nation's oldest and largest nonprofit committed to improving care and expanding options for the end of life. She has devoted the past 6 years of her professional life to this work and strongly believes that information, support, and options at the end of life are basic human rights and critical pieces of living and dying healthfully. Welcome to Wide Angle, Marie.
Thank you.
Thanks for joining me.
Thank you.
I guess, first of all, let's unpack a few terms that are frequently used interchangeably, but that in fact are quite distinct.
Mm-hmm.
If you could, distinguish between assisted suicide, euthanasia, and what Compassion and Choices is advocating, medical aid in dying.
Sure, happy to.
Yeah.
Well, the term physician-assisted suicide is a misuse of terminology because the people who are terminally ill they want to live. They don't want to commit suicide.
Yeah.
And it's their disease that's killing them.
Right.
So what they reach out for is the option of a prescription so that they can die peacefully.
Right.
I mean, they're dying anyway.
Right.
And rather than go through, because some of the end of life for some people is horrific,
Sure.
and rather than go through that unbearable suffering, they want the option to be able to take a medication and lay down and go to sleep and die peacefully.
Right. Yeah. As distinguished from a euthanasia.
Yes, and euthanasia, in contrast to medical aid in dying, euthanasia requires someone other than the person who is dying to administer the medication. So it could be a doctor or a healthcare professional,
Sure.
and they will administer the medication for you to then die.
Right.
And
So it's about
euthanasia.
It's about control, effectively.
And euthanasia is illegal in the United States.
Okay.
And so it doesn't, it has no relevancy to our bill in Massachusetts.
Right.
And also about assisted suicide is that it's very clear in all the legislation that suicide is against the law.
Right.
In all the medical aid in dying legislation, it's very clear that
Right.
suicide is against the law.
Okay. So medical aid, as I gather, is a right that is up to the states to decide. 6 states have already determined this, I guess, in their order of adopting the language. It's Oregon, Washington State, Montana, Vermont, California, Colorado, as well as District of Columbia.
That's correct.
Where it is legal. Not just anyone, however, has the right to access this law, right? So what are the states saying are criteria for people to access medical aid in dying?
We have used the model of Oregon, that 20-year history,
Right.
and that model is what we've used in every state. We have legislation in probably 26 states right now, and in the states where it is authorized, there are probably, and I'll just speak for the Massachusetts bill, there are probably about 15 safeguards in the bill.
Right.
So one is you have to be terminally ill,
Okay.
with a diagnosis of 6 months or less to live, and so the prognosis of 6 months or less to live by your attending physician. An additional physician needs to be able to confirm that. you have to make 2 separate requests, a verbal request, and then there's a 15-day waiting period where you make a written request, and that request has to be witnessed by 2 people, one person not having the ability in any way to benefit from your estate.
Right,
The other criteria is that medication cannot be prescribed until mental capacity is determined by a mental health professional.
Interesting.
So patients are not eligible for medical aid in dying if they're elderly or if they're disabled,
Right.
just for those reasons. I mean, they have to be, terminally ill with 6 months or less to live and meet all this other criteria.
The talk of safeguards suggests that there are certainly those, and they may be those who support bills like this to begin with, but there are those who are concerned about the safeguards. Yeah, that a right to die law effectively may be used against the disabled, which you spoke to. That the ill and infirmed may feel pressured to not be a burden. And this is one way to make sure that they're not a burden. And that ultimately there are certainly those who would suggest that medical aid in dying, anything similar, in some way cheapens life. And I'm sure you have responses to those concerns?
Well, in the 20 years that medical aid in dying has been practiced in the state of Oregon, there has not been one case, one instance of reporting of any kind of abuse. In fact, the Oregon Disabilities Law Center has sent us letters annually to state that, there has been we have had no one come in or contact this office to say that they were coerced or in any way, through the medical aid in dying law. When you talk about coercion, when these people make these requests, I mean, there are 2, 3 doctors involved. It's very clear if the person is not mentally capable and not doing it of their own free will. I mean, that's what you're trained to see. You're trained to know whether someone is really there and present or if there's some family member pushing them, you know. A person comes in very differently if they have been pushed into something like this. And they have to take the medication.
Right.
You can't do that.
Right. This next question you've brushed up against already, but I want to ask it because it connects with a local Brockton doctor, Roger Kligler, who a lifelong doctor, certainly who's worked with patients who have dealt with terminal illness and therefore speaks from that vantage point. Also is, I gather, a 15-year cancer patient himself.
Right.
Stage 4 prostate cancer, I gather. Last year, Boston Magazine published an opinion piece that he wrote that I would highly recommend everybody interested in the issue read, because from having a doctor's perspective and somebody speaking from the inside out to this issue is very powerful. So let me read this and then ask a question to it. I don't know when death will arrive. It could be in a few months or a few years. In all honesty, that part doesn't scare me anymore, and I don't devote much time or energy dwelling on it. What does scare me, however, is the strong likelihood that I will spend my last days on earth unable to do the normal things that make life enjoyable, losing my autonomy and dignity, being barely alive, yet in severe pain, drifting in and out of a morphine-induced haze while my loved ones take shifts on a death watch. That is not how I want to die. Would you? And of course, that's the central question here is would each of us? And I suppose we need to put ourselves in this equation and ask ourselves, what options do we want if we were the ones in that position? Certainly, I've read of Brittany Maynard, the then 29-year-old 4 years ago, who moved from California to Oregon with stage 4 cancer, to take advantage, really, of their death with dignity law. I heard the same in her, there being a relief that there is this option. Yeah. In Roger's case, Dr. Kligler, he says, I don't know that I'll use the prescription if Massachusetts enacts this law, but simply having that opportunity is something that will allow me to breathe a little bit more freely. Yeah. So, and I gather that is a common experience that we hear from those with terminal illness that have access to this right. Is that right?
Yeah.
Okay.
And Governor Jerry Brown, when he signed the law in California, said that same thing in his signing.
Yeah.
That I don't know that I will use this.
Right.
But I want this option there, and I want others to have this option, And I hear that all the time. I mean, I've talked to thousands of people across the state, and I hear over and over, I'm not afraid of death, but I'm afraid of that suffering at the end. That's a very common, a common phrase. And people that have witnessed, and many of us have witnessed family members, that have suffered so severely at the end. So you say, I don't want that, I mean,
giving the option of a medical aid in dying law to those people with terminal illnesses who may choose it is certainly putting more control in the hands of the individual, which, as we said, by itself could be very relieving in its own right. Interested in how this impacts families. Yes, I mean certainly the end of life, the end of life does anyway. But this, and particularly it being so sort of out of step with where our country has come, and it being a unique experience. What is your sense of how families deal with it?
Well, I actually thought you would ask this question or something like it, and I brought with me part of a testimony. From a woman who testified at the hearing in September, who she's a Mass resident and spent 32 years living in Oregon with her husband and raising 2 children. And her husband became ill and spent 5 years fighting cancer. And I'll read part of her testimony. She says her husband endured a 5-year battle with cancer, and she shared how there were times when the pain was unbearable. After he was told he had 6 months or less to live, we began the process to legally obtain an aid in dying prescription of Nebutol sodium, which he could drink if and when only he decided to do so to peacefully end his suffering. The week prior to his chosen date, he spent time visiting individually with each of his closest friends and relatives. He reminisced, shared stories, laughed, and loved, all so grateful for the opportunity to say goodbye. On the day of his choosing, he took a single dose of Reglan, an anti-nausea tablet, which was to be taken 1 hour prior. Each of our 2 children, ages 12 and 14, and his sister individually went into the bedroom to talk with their beloved dad and brother and said their goodbyes. Then I lay with him alone, loving him, supporting him, knowing this was what he wanted to do. When he decided it was time, he took the glass in hand and calmly drank the medicine. Within 5 minutes, he closed his eyes and slipped peacefully into a coma. Soon after, I told the family to join me, and we gathered by his side. We all knew this was his decision. It was the way he wanted it, and we were all supportive, loving, and strong. We continued to talk to him and tell him how much he was loved, that we were all going to be all right, that it was okay to let go and move on to whatever is next. In just under an hour, my husband had slipped away, and when I asked his hospice nurse to come into the room, she listened to his heart and told us he was gone. The experience is one which we will carry in our hearts for the rest of our lives, and what we carry is a peacefulness, a calmness, and a strength that only we and those in our circumstance can fully understand. Weeks later, his hospice nurse shared that this passing was the most peaceful and loving death she'd ever experienced. she'd been a hospice nurse for 25 years.
Yeah. Well, what do you say after that?
I mean, I hear those stories.
Yeah. Well, and that's the follow-up, right? Because certainly families are as unique as the individuals who comprise them, but is that sort of testimony typical of families that have gone through this experience?
It is, and isn't that the kind of ending you want to have with a loved one rather than someone who is slipping in and out of consciousness with all kinds of tubes in them or whatever, and the family is doing a death watch for 2 weeks. I mean, because those images stay with people, and when people testify, they talk about what the horrific end was like. But to have a beautiful image like this, you know, which I've heard from many people, is what we all want.
All right. On that note, we're going to go to break.
Okay.
And ask people to join us on the other side, where we'll explore efforts underway on Beacon Hill to give Bay Staters the right to medical aid in dying.
We'd love to hear your feedback. Email us at wideangle@acmi.tv. For information about this episode or to view other Wide Angle episodes, visit us online at acmi.tv/wideangle.
Welcome back to Wide Angle. I'm Peter Bermuda speaking today with Marie Manis of Compassion and Choices about medical aid in dying. All right, so a few administrative questions which sort of run the risk, Marie, I think, of sort of being, superficial, sounding superficial and sort of almost irrelevant in the midst of such a profound conversation. Yeah? And yet, I know certainly they impact families after their loved one is gone, regardless of how that happens.
Sure.
So if I can, just a few points. The death certificate will state cause for death. In the case of medical aid in dying, what does it read?
The underlying illness is the cause of death.
Okay.
Just as in any situation, if someone if someone stops dialysis, kidney failure is the cause of death.
Okay.
Not that they stop dialysis.
Okay. So it follows.
Yes.
It follows how those
It
are
follows
typically
the way it's
filled out.
typically done.
Okay.
Yes, the cause of death is the underlying illness.
Okay. Medical insurance. Is medical insurance in the 6 states and D.C. covering this sort of care?
For the most part, yes.
Okay.
My understanding is most health insurances cover this. Yes.
Okay. All right. And lastly, the issue of life insurance. So certainly in the case where, and not that I even want to draw a parallel, but in the case of suicide being listed as the cause of death, life insurance does not pay out. What is the case in medical aid in dying?
Because it is not suicide, clearly not suicide, and states in the legislation and in the laws that it's not suicide, insurance is paid out.
Okay.
There's never been an issue, and it's very clear in the legislation that insurance is covered.
Okay.
Yeah.
Very good.
Yeah.
All right. So on with
Because
sort of
again, the person is dying from the underlying illness.
exactly.
Yeah.
Exactly. And this is just offering them an opportunity to exert some measure of control and agency on the situation.
Yeah,
All right. As you noted early, Oregon comes along with 19-20 years of experience with the Death with Dignity Act.
Right.
I gather that sort of a 19-year longitudinal study, some data, was just recently released. I gather one of the things suggests, one of the findings is that, and it extrapolates a little bit, states that have a Death with Dignity Act or something similar to that actually end up having more robust end-of-life care more generally.
Yes.
Yeah, which maybe strikes as counterintuitive, but can you give some context to that?
I mean, what I can say is that, there's been such a shift in medicine, as you know, I'm sure.
Yeah.
Much more, centered patient care, patient-centered care. And in the states where medical aid in dying is authorized, it's an opportunity for doctors to really have discussions with patients. So they have to sit down and not only talk about medical aid in dying, but talk about all the options.
Right.
You know, you can have hospice, you can have palliative care, you can have medical aid in dying, you can have all of those, you know, things. Right. So it's given doctors the freedom, and doctors have never been trained in the past to talk about end of life. And this is starting to change. You know, doctors are being trained little by little, you know. And in the states, you know, in Oregon, you know, for example, you know, 90% of the people that use medical aid in dying are in hospice care. In California, they found that there's been a huge, and that law's only been in effect for a year now, there's been a huge increase in the number of people having these conversations with their doctors. So it's really opening a door that had been closed because you don't talk about death.
Right.
You don't talk about end of life. You know, and even doctors, I mean, I've sat and talked with doctors who say, you know, you falsely give people hope.
One of the interesting things, another interesting thing that I read of in connection with this was the point of view of a doctor who was suggesting that, you know, without the ability to talk about something like medical aid in dying for the terminally ill, the notion of informed consent, which is central to how we do medicine in this country theoretically, informed consent really isn't met. The criteria really aren't met unless those decisions can be talked about.
Exactly.
Right? So theoretically there are doctors having the discussion that, geez, that it's good if we can. We're actually living our oath more fully if we can have this conversation.
And doctors want the help, they want the training to be able to have these conversations, to comfortably be able to do that. So there is definitely a big shift, you know. I mean, there was a Medscape poll done in 2016 across the country where I think it was 58% of doctors support medical aid in dying, up from about 52% in 2010. And then when the Mass Medical Society did their survey across the state, 62% of doctors supported it and supported the legislation.
Right, and
that's huge.
I'm sure, and you speak to the Mass Medical Society. Mass Medical Society, I gather, just recently rescinded its opposition to medical aid in dying, adopting what is called a stance of neutral engagement. So what does that mean?
It's actually much stronger than the other 10 medical societies that have dropped their opposition and gone neutral.
Okay.
Neutral engagement means that when the law is passed in Massachusetts, they will train doctors.
Interesting.
And whether the doctor chooses to use, you know, a practice medical aid in dying or not, they will train doctors. That's huge.
Sure.
I mean, Mass Medical Society is one of the most conservative societies within the AMA.
Right.
So that's just pretty amazing.
Sure.
Yeah.
So doctors will be the ones who are, as is true with other prescribing issues, they are the ones who would do this, or would help with this. And they would, I guess, be self-select as to whether or not they wanted to be involved in this part of medical practice.
That's correct.
Okay.
Yeah.
All right. And I suppose along with that, is an evolving understanding of, you know, the first do no harm piece of what doctors theoretically are pledging allegiance to, as it were, when they become doctors. That helping someone with an end-of-life decision can be consonant with not doing harm. That can be part of relieving pain.
And that's how many doctors see it.
Yeah.
You know, to be able to give a patient that peace at the end of their life means doing no harm.
Right. So we're talking Massachusetts, Mass Medical Society changing its position. You referred, I think, earlier to back in 2012, there was a ballot question in Massachusetts on this issue. You were here for that work.
I was.
It was narrowly defeated, I gather. Shortly after, and I guess still continuing, are polls suggesting that upwards of 70% of Massachusetts voters support a law like this.
As do about 60% of Catholics within the state, and
Right.
as do about 60% of folks with disabilities in the state.
Interesting.
The education that's gone into the state over the last almost 6 years, you know, people can't be fooled
Right.
by a few TV ads.
Okay, all right. You also said, you also suggested that, what, I think since last year at roughly this time, January of 2017, that some 27 states have introduced or been continued to work on this sort of legislation. So what is going on, particularly in Massachusetts today?
So in Massachusetts, we introduced a new bill in Representative Lou Kafka has been amazing. I mean, he's been introducing this bill since 2009. He had a constituent who had cancer, spoke to him, asked him to introduce this legislation, and he's been doing it each year. And each year we've built and gotten more and more co-sponsors on the bill. So this year we have about 46 co-sponsors, which is about a quarter of the legislature.
Okay, and I will say for viewers that Senator Cindy Friedman is one of those sponsors, yes, who represents Arlington. Neighboring Lexington, Jay Kaufman, Somerville, Pat Jalen are also sponsors of the bill. Okay.
And so we reintroduced it in January of 2017. And the bill went into the Joint Public Health Committee. We had a public hearing in September, great turnout, about 170 people turned out. And I think it was more than 30 people that spoke in favor, everything from doctors to faith leaders, to social workers, people with personal experiences, hospice, I mean, just a whole range of people spoke in support. And it's been in, so the bill has been in committee.
All right. I'm sure that there are viewers who are interested in learning more about the issue, conceivably in getting involved in some way. Resources that you can direct them to?
To our website, compassionandchoices.org. They can go into volunteers and fill out a form. They can go to it says Near Me, and then Massachusetts website to get more information about what's happening in Massachusetts. But that's a good way. Sign up as a volunteer. I will get that form, reach back out to them.
Excellent.
Yeah.
Well, I thank you so much for your time today, Maria.
Yeah, thank you.
At the end of such a conversation, what remains to be said? Although death is a universal experience, it is accompanied by an entire palette of feelings, emotional and physical, that are highly personal and which no outsider can truly comprehend. But there, it strikes me, is the phrase that begs our attention, that no outsider can comprehend. Lacking direct experience, even the most imaginative and empathic amongst us is at a loss. But we nevertheless have decisions to make on behalf of one another. One of those decisions is creating a healthcare system truly dedicated to our health and that supports people going through these challenges by removing the additional stress and anxiety of funding and managing such vital care. That, of course, is a larger issue we haven't mustered the political will for yet. A smaller but still vital decision has been the focus of today's conversation, one that might help those with terminal illness breathe a sigh of relief, even if never ultimately acted upon. Would I want access to such a choice? Might my loved ones at some point? Would you? On behalf of Marie Manis of Compassion and Choices, I'm Peter Bermudez. Thank you for joining us for this edition of Wide Angle.